am so excited to introduce you today to Sam Visnic, Release Muscle Therapy. How are you, Sam?
I'm doing fantastic here, and I'm very excited to be on this podcast here and have this chat.
Oh, me too. We already started talking a little before I hit record, and I'm like, I just need to press record because all of this is already awesome. So here we go. Give our audience your background and what you're currently doing.
Well, by trade, I would say I am a clinical massage therapist, and make the distinction between clinical because I'm not doing just kind of traditional relaxation massage therapy, even though that relaxation is always a part of massage. But my work is generally focused on individuals that are dealing with specific structural and physiological problems, namely chronic pain. So that work is going to involve looking at all of the different elements that contribute to pain. And obviously, I'm doing hands-on therapy with them, but I also do a lot of movement-based work as well. And that's the central kind of focus or circle around my work with chronic pain. But when we're dealing with chronic pain, it's a far more dense topic. There's a lot of surrounding factors that contribute to the maintenance of these kind of chronic pain elements and why people's bodies are having the problems that they're doing. So I've extended out over time into some of these other realms and looking at some of these, what we would call biopsychosocial factors and how they contribute to these elements. And that might involve looking at, again, things like your specialty, nutrition, or their deficits with what people have going on there. Are they not sleeping well? All of these different things, and kind of providing some coaching in that realm with them, and just basically helping them kind of develop an understanding of the complex web of dealing with these chronic pain issues and helping them get solutions to basically overcoming them.
Yeah, I love the whole picture approach. Don't you think it would almost be impossible if you didn't help with setting the goals and the talking? Like, if pretend I'm a client coming in, before I even go to the table, do you have like what's a session look like?
Well, and speaking to that right there is that's probably 99% of what happens out there is not dealing with those web elements. So for me, I think over time, it's taken a long time, but developing a way to figure out kind of like who my ideal clients are. And most of the time, they're people who have been through multiple layers of practitioners. They've definitely been through the medical system. So most of the time when people have any kind of ache or pain that's lasting or is threatening or stressful, they end up in the doctor's office. You go to the doctor, naturally, good thing to do, find out something's really going wrong. And by then they're usually cleared. They may have done MRI, X-ray, something like that. And usually the second round after that is going to physical therapy. So they've gone to PT, done general core exercises and, heat, stim, et cetera. And at that point, they're discharged. And at that point, a lot of times when people are better, most of the time, they feel better, say, oh, PT helped. My doctor said there was nothing wrong with me. And yet that I go to physical therapy, that helped, those exercises. But then they discharged me. And, usually I'm working with active people that are already doing something. They like to cycle on the weekends or they're runners. And they say, well, I'm not able to go back to doing my sport or my activity because this issue is still happening. So now, the medical side is kind of done with me. They said, I'm fine. But yet I can't do what I want. And this is what I call the gap. And the gap is where people oftentimes are just kind of searching around. And this is where they end up in the alternative health field, looking for alternate options other than the medical system, the traditional medical system, to try to figure out why this issue is still happening and how they can basically overcome it to get their life back. So that's the realm that I kind of work right within, is where kind of like as they exit the medical system, but yet, they're between a rock and a hard place, so to speak.
I could see listeners' ears perking up at the moment or shoulders relaxing, going, there's somebody out there that covers that gap. What?
There is.
Do you find, is that a common response to you? Like, how do I not know about you?
Yeah. And there is I've had so many conversations with different practitioners. There are a lot of practitioners that kind of exist in this space. But the range of things that they do is very different. So you might have practitioners that do kind of an isolated based therapy. And in my realm, when we're talking about exercise, movement, massage therapy, there is dozens of them. And this oftentimes presents itself as different types of techniques. So there's somebody might do myofascial release technique, or somebody might do active release technique. So there's a category of these techniques that are oftentimes aimed at these individuals and helping them overcome their problem. but it is still a very small corner of that entire situation that the person is experiencing. Saying that, this one technique is a soft tissue technique. So we're going to do this massage work on this muscle or this back issue that you've got, and that's going to fix all of the problems. Now, of course, that might take care of a small chunk of people that issue really is helped by that technique. But then there are a lot of people where that's not the only thing that's contributing to their problem. As we mentioned, that pain is a complicated animal, and there's oftentimes many factors that are contributing to it that are not necessarily 100% structural biomechanical based. So, that would lead into maybe other practitioners that do other things. For example, you might find a nutritionist who deals with helping people with inflammation because maybe they have an underlying health issue that is causing inflammatory reactions in their system, and that's making their nerves sensitive. So that person might end up in that nutritionist's office working on inflammation, and that'll help a certain chunk of people. So we're kind of in that land where, like, once the system kind of goes wide into the gap, there's lots of subspecialties, and some practitioners do multiple and some don't only do one thing. So that can oftentimes be a sticking point for people too, if they end up in the wrong practice for their needs.
For the person who is really new to all of this and going, okay, I'm hearing all of this, but where do I start? Or what are the
Yes.
right questions for me to ask to know that I'm even landing in the right place? How do you get someone going on that?
Well, first of all, what we do, and my work involves, I think one of the things that's been missing largely from virtually all health care practitioners and practices when it comes to dealing with pain is pain education. We oftentimes don't teach people about pain because we think about it, the presupposition there is the inference is that pain is an obvious thing. Something is clearly damaged, something is clearly wrong with you. And when we fix that, the pain goes away. Well, there's a problem with that. And the problem is a fundamental misunderstanding of pain that most people have. So I help people understand that pain can be lots of different types of pain, but we chunk it into two main categories: acute pain and chronic pain. Now, acute pain is a really obvious one. If you roll an ankle, you break a bone, we look down, there's swelling, there's injury, there's a lot of pain, obviously, because you've damaged tissue and your nervous system is trying to stop you from further damaging it or giving you information to say, hey, take care of this. That makes sense to us. And all of those types of injuries, provided you have the appropriate medical care, is going to have a finite amount of time to heal. You break a bone, you put a cast on it, it heals in 8 weeks. You pull a muscle, that might be 3 weeks. You get severe car accident damage in your body, that could take a couple of months to heal all of those tissues. So those are things that we know, right? And our minds can easily make sense of that. We have acute pain. I just have to wait for this tissue to heal, and then the pain will be gone. Now, what happens is at a certain point when tissues have healed, and experts generally agree on this, that in 6 months, everything in the body heals. So even if you were gotten a really bad car accident or you had a serious injury, all of those tissues will have been healed by 6 months. So if somebody is having pain after 6 months from that issue, is it from the tissue not having healed, or is it you're left with something else that is the nerves are still sensitive, or you're having pain after the tissue has healed? That is what we refer to as chronic pain. So chronic pain is pain that persists after the expected time of healing. So when we teach people about pain, and there's a lot of information that validates this in the research and the studies, this is a whole field of talking about pain in neuroscience, that we're not dealing with in chronic pain as a tissue issue. We're dealing with a nerve issue. So I do find it funny when people go, I think I have more of a nerve problem than a muscle problem. And I say, well, that's almost always the case. Muscles are kind of stupid. They just kind of lay there until you electrocute them, and then they dance. That's what your nervous system does. Your nerves, electrocute those muscles to say contract, and to what degree. So the nerves are always kind of the central unit. So when we teach people about pain, we teach them the difference between those two things. And when you're dealing with chronic pain is a completely different animal than acute pain. But yet our systems, when it comes to most health professionals, doctors and so forth, will oftentimes treat chronic problems as if they were acute problems. So if you've had back pain for 2 years after an injury, remember, theoretically, that tissue has healed. And then you go to the doctor after 2 years of having lingering pain, they'll oftentimes run an acute diagnostic test. They'll run an MRI or they'll run an X-ray, because of course they're going to be looking for underlying pathology, make sure there's not a tumor or something there. But a lot of times what they're going to find is not much. And there's people get frustrated because they're like, well, if there's something wrong with my back, shouldn't you see it? And that's not exactly how it works. Because a lot of people, and the studies will show this, if you take 100 people off the street randomly and you run an MRI on their lower back, approximately 65% of those people will show something wrong with their lower back, whether they have a disc bulge or they have arthritis or they have any of these things. But when you survey those people, a good chunk of those people have no pain or symptoms at all. So we run into this problem with acute and chronic that they oftentimes get pulled in together when they are really should be dealt with in separate ways.
Man, what a fabulous explanation. And you even covered where I was going to ask, somebody who you can't see any disc bulge or anything physically wrong, but they're still saying like, I am in pain. Again, that comes back to, you feel like nerve at that point, I guess, just for the person going, I've never been diagnosed with anything, but my lower back always hurts.
Yeah. So this goes into a good conversation as well as an extension from that. Approximately 25% of people with chronic pain have never had an injury, and there's no incidence where it started. So 25% of people with chronic pain never started from anything obvious. So no injuries, not even what I was talking about, having had an injury and then, it going on from there. So the challenge is what causes pain? And this goes into this conversation of the neuroscience of pain. And, we have, for example, lots of nerves in our body. And what do nerves do? Nerves communicate information. They're kind of a highway, right, between 2 points to, translate information, to tell things to occur, but also to sense things, to feel things. So, anything you can feel in your body, there's a nerve receptor for. You could feel temperature changes, you could feel pressure, stretch, any of those things, fatigue, lactic acid. So all of that information is what those nerves process in your body. And through those nerves, it sends that information up the spinal cord to the brain. And the brain is the central processing unit, if you could think about it that way. And it deciphers that information. Now, it's important to understand that the nerves send information in a neutral format to the brain. So the nerves are just saying, this is how much pressure there is, and the amount of information can accelerate, or in terms of intensity, to give the brain input of how much is occurring, because we could all feel a little bit of pressure versus a lot of pressure. But the brain is up to determine and assimilate that information to determine what that means. And if that information is threatening, meaning it poses a threat to our survival or to potential injury, our brain is going to create a reaction to that stimuli to protect us. And it's a primitive thing. And the easiest way to do that is to produce a feeling or an experience that we call pain, because it's very noxious for a reason to interrupt whatever it is that you're doing, to tell your conscious mind to pay attention and to take some kind of action. So we have two processes that occur in pain. We have the information that's coming from the body going to the brain, and then we have the brain processing that information and reacting to it. So we call this the bottom-up and the top-down approach. Now, we mistakenly oftentimes believe when it comes to dealing with pain that almost this entire process is dealt with by what is happening in the tissue is guiding and directing that entire process. And that is not true. There are lots of people who have pain that are not getting that information that is threatening in their tissues. And probably the most extreme example is phantom limb pain, where people don't have a limb, but yet they feel pain. The limb doesn't even exist. There is no information coming from the limb. So where is the pain being generated? It's being from the brain. The brain is sensing a threat and an alarm, and even though the information is not even there. Okay, so this is brain. We say that pain is in the brain, not because it's a psychological process, but because the central processing unit, the main computer that processes information, is in the brain.
So interesting. Okay. So I feel like I might be jumping the gun by asking this, but
I say, let's go for it.
I know that anyone listening is going, got it. I hear you. now what? Like, what are you going to offer me now that now that we've covered all this?
Yes.
Is there hope for me? Is anybody a lost cause?
No. And
Okay.
that's the best news, is that once you understand what is happening, it starts to take this realm where you think that there is a finite or a limited amount of options to help you. And it does this, and you go, I've tried everything. And I go, no, you haven't.
Oh, I love that.
There's lots of
Yes.
things that you have not tried. And because we have multiple things to play with, so we have the information that's coming from the tissues going to the brain, we can change what you feel. We can rub those tissues, we can compress those tissues, we can put heat on them, cold on them. We can stimulate every receptor that you could possibly feel. And that is going to send new information to your brain. And we can see how your brain feels about that information. And a lot of people have experienced this with chronic pain. They have felt things they know work. Sam, when I put heat on my shoulder, that's the only thing that works. But massage doesn't make me feel better. Or when I move my shoulder like this and it pops, it always feels better. So people oftentimes are telling us exactly what it is that they need, or which receptors or information seems to change the signals going to their brain. But they don't understand why it's happening. And that's what my job is to do, is to help them interpret that. Why does this work? Why is it that when I move my neck like this and it pops, the pain goes away? Because there's something that is occurring in there, right? So we can do all of those things to manipulate the receptors and the information going to the brain. But we can also do things to change the brain's interpretation of this information. So one of the simple things I do is ask people how they're experiencing their pain. I understand pain and the mechanisms for how it works, but the problem is that pain is a 100% unique experience. You have so many different people that are literally experiencing their pain in a different way, and we can't use the same approach with everybody. So the question is asking and getting feedback on how they're experiencing their pain. One of the things I always find entertaining is that when people are told about disc issues and arthritis in their spine. Now, as a health professional, and it's just like the work that you do, I'm sure you're aware of this too, is that when you think about things, you're very educated on the topic. And when you think about things in your mind, you have beliefs, just frames of reference, you know what these things mean. But when somebody is told you have degeneration in your lower back and severe arthritis, most people are like, when I hear that, I just shrug my shoulders because it doesn't mean much to me. I understand about pain. And I understand that those orthopedic things don't mean pain. But when somebody else hears that, I always ask them, when you think about a disc bulge in your back, do you even know what a disc bulge looks like? And most people will go, no. So they've never even been shown what a disc bulge looks like in terms of a picture. And that they feel very threatened by what this is. So my question is, what movie do you play in your mind when somebody tells you this?
Right.
Because they're oftentimes playing this horror movie of spinal vertebrae collapsing on each other and all of this craziness going on. And yet when they play that movie inside of their mind, their nervous system is immediately reacting to that threat. And that is very threatening information. And if you make movies of your spine falling apart in your mind, and then I ask you to go do an exercise, how's that going to go? Because if you think that that's going to make your back break in half, you're going to feel more threat and more guarding, which ironically stunts your rehabilitative process, because you now need to be able to do those things in order to feel not threatened by them. So when we put that stuff together and we say, we take that top-down approach and that bottom-up approach, and that's just looking at movement from the work that I do. It's not uncommon for people to come in and they have lots of other things going on with their health and their well-being that definitely puts their nervous system on a little bit more guard or more threat. And those are lots of things where people who are having pain and they have a lot of stress and anxiety and worry maybe about their pain or other things, and they don't sleep well, or they're not making good food choices. They don't drink enough water. And these are all things that are probably relatively easy things to address, because most people don't know that they're associated to these issues in their nervous system and might be provoking their pain. And we should address those too. So again, we get that point where like, I have a shoulder problem and this is a very specific muscle problem. And I did every therapy for that specific muscle problem and I'm hopeless. And I go, Not really.
Hmm. And so hopeful to hear that. What do you tell the person who's getting frustrated because they feel like they've done 3 or 4 things and they haven't hit that yet? Like, where's the hang in there pep talk?
Yeah. Well, I think it's this, getting on and listening to this kind of a podcast. And, it's very exciting to be like, wow, this is crazy. This is a whole new realm of stuff that I haven't learned. And I tell people that, again, it's your nervous system has an infinite ability to adapt. And that's really what we're looking at, is that we get into repetitive patterns. And human beings, we do this in all sorts of contexts in our lives with our behaviors, where we do the same thing over and over again. We think the same thoughts, and then we kind of limit our scope and our view of reality until something comes along and kind of shatters that. And then we realize, wow, there's a whole nother kind of realm of things I haven't considered before. And then there's the opportunity there. The opportunity is to delete that information and keep doing what you're doing. And a lot of people might say something like, oh, yeah, but my problem is different. And go right back to thinking the way that they're thinking.
Hmm.
Right?
I
That's
can
pretty
see that.
common.
Yeah.
Well, my problem is different. Right? Or we take that information and then we start to kind of entertain that and to try to find additional resources. Now, the good news is, maybe 30 years ago, that was much more of a problem, having this conversation, because otherwise you'd end up in the local library trying to hunt down books on the topic. But now we have the internet, so we have keywords and we have things to look for in Google. And it can help us move closer to finding the resources that we want to find on this.
Aren't you loving this about podcasting too? Is that you can have this conversation a few hundred times in first instead of thousands of times, patient by patient. It's like, here, listen, I love these resources to just dump into people's texts and say, just give it a listen, see what you think. Have any of your clients almost made you convinced that they are a different cause? Like, have you ever gotten to that point where you're like, oh, what are we going to do with this person?
Yeah. And, that has, over the years, that has always kind of been the space that you work in within the clients that I've seen. You handle certain cases and classifications of problems, and you're making really great progress. And you're like, I've got it. I've got the master formula, right?
Yeah.
I have it all figured out. And then
Yeah.
somebody comes in and then you're like, all right, I don't have this figured out. I don't know what's going on here. So you have to go with that too.
Yeah.
But I think that, and this has kind of been the recent thing that has been, I think that is an undiscovered kind of component. One of the things that I think even in the field has admitted in pain neuroscience and experts on pain is how underdeveloped the component in the research and the quality of the research has been on nutrition's impact on inflammation and pain.
Yeah.
So it just hasn't been done. And it's an area that I think that needs to move much further forward. And in particular, we're looking at things, I think the research on some of these conditions that are coming a little bit more, or say a lot more well known, because we're seeing so much of it, is these chronic inflammatory conditions of the GI tract, the gastrointestinal tract, looking at things like SIBO. And SIBO is now just exploding because there's so much more information available on it. Lab tests are becoming much more widely available to test for these different types of SIBO, and seeing these inflammatory conditions that are really just creating a lot of background noise in the nervous system and creating inflammation through the immune system. It's making nerves more sensitive. And then therefore, when they're presenting, they may not always have gastrointestinal symptoms. They don't have bloating, they don't really have gas, nothing really going on, but they're clearly dealing with some kind of hidden source of inflammation. And yet they seem to just have a strong amount of overreactivity or sensitivity to general therapy techniques like massage and exercise. So they're not progressing in an expected way. So I will see those cases where you see things and you really just get the feeling that something is going on behind the scenes, but you don't know. And that's where it becomes really crucial to work with a team of professionals who you can refer out to that can identify these underlying problems and see if there is anything there. And that's definitely those kinds of cases that I'm now much more aware of, is that when I get the feeling, the intuition, right, after just years of working with people, when things don't seem to be progressing in the way that we expect.
Right. I like that. You're going to have to back up for 1 second for our listeners and explain SIBO.
Okay, well, you're going to know a lot more about this topic than me, but small intestinal bowel bacterial overgrowth, which is the microflora imbalances that can be the result of a lot of things. And from antibiotic overusage, for example, poor diets, lifestyle stress. I think another one in there is that even just having a bout or two of food poisoning can really set you up for SIBO. One of the things that has become more apparent on my radar is things like, for example, traumatic brain injuries and
Hmm.
what the role that traumatic brain injuries has on generating gastrointestinal problems, which is amazing that how many people might even not be considering that.
Right.
And of course, having a traumatic brain injury, that resulting in gut dysfunction. Now the gut dysfunction is now feeding the inability of the nervous system to recover. So now it's going like this. So we're really, I think, getting to this point within the health realm of really understanding a lot more about the integration of all of these different systems, which behooves us to start reaching out more and creating better and more fuller collaborations between these different health disciplines rather than seeing them as so separate from each other, which is unfortunate.
Right. On any given day, I feel like we've gotten so much further ahead. And then on some days I'm like, nope, still have a ways to go. But I'm even picturing as you're talking about some of your patients really needing to like rewrite that story of what they're telling themselves, that psychiatry probably comes into play a lot with this as well. Can you talk on, I don't want to just go down a fibromyalgia path, but can we talk fibro for a minute?
Absolutely. It's becoming one of my favorite topics to talk about. It used to be
Oh,
one of my
good.
most feared because in my profession, kind of classically, fibromyalgia has been one of the more difficult kind of challenges that we've been up against as a manual-based practitioner. And those of us who are not fully aware of this is that fibromyalgia is essentially a syndrome of increased or maladaptive response to stress. So a nervous system that is very sensitive and can vary dramatically. So if we back up just even more for a second, here's different classifications of pain. We have that general one that most of us are familiar with. You get a bump in the arm or you pull a muscle. This is more of what we would call nociceptive pain. So we have information coming from the tissue going to the brain going, ouch, I'm injured. And it's very straightforward stuff. We have another classification that's more like kind of nerve pain that we would see, for example, like sciatica or carpal tunnel. These are nerve-related types of pains, and we call them neurogenic pain. Now we have a third classification, which is kind of the new kid on the block, which is this kind of pain that is more widespread. And the issue is that it's more along the lines of that the brain itself and the processing component of the brain and the way it's perceiving information from the body is now distorted. So, for example, non-threatening information can be perceived as threatening. So a good example of this could be when somebody is sitting at work typing and the air conditioning comes on and it causes pain in their neck when the air conditioning hits the skin on the back of their neck. That information is non-threatening, but the nervous system is interpreting it as threatening. So this is a dysfunction of the nervous system itself. And this is what we call nociplastic pain. And nociplastic pain is known to be very variable, meaning that one day I do massage work on a patient and they feel fantastic. I do that massage work on them the next session the exact same way, same pressure, and now that person has pain as a result of that massage. This is classic characteristics of fibromyalgia. And that's where a lot of manual-based practitioners and exercise-based practitioners struggle with individuals with fibromyalgia because there's no clear-cut path on how to work with them. It really varies.
Mhm.
So the patient is very frustrated because they're seeing somebody that they perceive to be knowledgeable on how to help them with exercise, but there's frustration coming from the practitioner, and both parties, more often than not, don't understand the circumstance that is occurring that's causing that to happen. In the last 10 years since I've been teaching pain neuroscience education, and many people with fibromyalgia come to me, and upon interviewing them, I don't think I've come across a single person who has even heard of any of this stuff, namely talking about something like central sensitization, which is a common theme in the pain field now. So nobody is talking about it, and they're certainly not explaining it to individuals with fibromyalgia. So a lot of times what I'm finding is by educating them on this and then also helping them understand like the context of what is happening in the therapeutic process, we could start to help them by kind of paving the pathway to determining which types of therapies and so forth might be helpful for them.
And where should, I don't care if it's fibro patient or if it's just a chronic pain patient, the expectation level be? Like the expectation should be they will continue therapy kind of lifelong, but get maintenance out of it? Or do you see kind of a start and an end to your therapy?
That is an interesting question. And I think that the problem that I have with this is that I don't like anything being finite, meaning, or infinite, I'm sorry, is that somebody is going to have pain forever, or, they're always going to be dealing with something. Setting an expectation that, hey, this is something that's going to require management, and telling somebody that they have a sensitive nervous system is different from telling them that they have a condition that they cannot do anything about that is going to always exist. I don't think we understand enough about what's going on to be so definite about something like fibromyalgia, because there's so many different presentations. I've had people that can do aggressive massage and can do all of the things that I wouldn't see with other people with fibromyalgia. So it's a very wide kind of field with this stuff as well. So what I'd rather teach people is it's something that's more of an in motion kind of discussion, meaning you have a sensitive nervous system right now. Mm-hmm. I don't know why your nervous system is sensitive. It may not stay that way forever, but what we can do is trust in the ability of your nervous system to adapt. And we know that over time, you may be able to tolerate very little exercise. You may be able to tolerate very little hands-on therapy. But as your nervous system repeatedly gets exposed to it, we have to trust that your nervous system starts to put a frame around that to say, this isn't bad and I don't feel threatened by this. And just in the way that people learn to adaptively cope with their environment and their surroundings that other people perceive to be stressful, but they don't, that nervous system will eventually learn adaptation to that environment and the alarms will go down. So they are able to desensitize their nervous system just like anyone else, but the speed and the rate at which they can do so is going to be dependent upon that person and what their underlying issues are that might be contributing to that increased nerve sensitivity. And as we go along in these fields and we start to find new things that might be contributing to that, we might find better and better solutions and ways to reduce that person's not going to suffer to the same degree for the rest of their life like that.
Yeah, I love that you mentioned that it's a conversation in flow. I think, our society is getting a little bit better about it, but the work that you and I do a lot of times is not covered by insurance. And I think that anytime a patient or client hears, you're going to have to, like, we do need this to be a relationship, come back in. And I think some people can just feel like they're just telling me that because it's money, and it's not. It's like we need time with people to get to those results, to figure out the next step. And it's not that we don't want to release people. It's that you need time sometimes too to like really understand. Do you run up against money barriers at all with your clients?
All the time, and most of the time, because how many people have they seen for pain before they saw me? And that pain, having chronic pain, is a very expensive process. Mm-hmm. I would say that I wouldn't see myself as being expensive considering what I'm offering, but to me, it's always the most expensive therapy is the one that doesn't work. So, and the one that doesn't work is the thing that promises, overpromises, and underdelivers, and also doesn't teach self-reliant strategies. Mm-hmm. My problem in my field in particular is that a lot of reliance on passive care. And passive care is that somebody's going to inject you, somebody's going to stick needles in you, someone's going to massage you or spinal adjust you, and then that's the end of the therapy. So when you leave the office, that's it. You were treated. And the problem with that is that chronic pain involves behavioral change. We have to change it. So therefore, there has to be things that have to be repetitively done in order to change behavior. And if that person doesn't give you follow-up things to do, then it becomes a reliance on passive care. That does not help you in the long run. And it's going to be very expensive. So I tell people, I'm going to do manual therapy because it's pretty rapid for me to be able to see how you respond to something and see how fast something might change if I do it for you. But then immediately I'm going to give you exercises and stretches that try to get that work to stick when you go home. And if you can get 10%, 20% of what I did by yourself, we're on the right track. And I can get that to get more and more stable over time, to the point where you should not need manual therapy if I taught you and your nervous system how to hold that position or to be able to replicate those results without me doing it. So I'm a conduit. I'm facilitating the process in the direction, not the perfection, right?
Nice.
You like that?
I
Um,
do.
but setting that course into the self-reliance. And we know that the research does support that, doesn't it? Is that when people have a sense of locus of control and they're making their own changes, that there's a whole cascade of neurology that kind of opens up and shifts in that person that are not just about the thing, but the interaction with the experience, which changes everything. So I think that fundamentally is what oftentimes gets missed too. But getting to that point takes time. And yeah, it takes a number of visits because we're trying to install those changes with somebody. So people do need to get enough exposure to us as their practitioners over a smaller unit of time. And then over time, keep in touch to continue reinforcing those behavioral changes.
Yes, thank you for honing in on behavioral changes. It's the thing that keeps popping up no matter whom I am interviewing, which is interesting because I feel like the really good professionals out there doing their due diligence with their job are always talking behavior changes. So it is even a team approach with just you and client that, like, I do my work, you do your work, and we will get there so much faster. This is fresh on my brain because I just got reassessed. I had an injury. I was going through my chiropractor, and he sent me out with my own stretches. And, as long as I was coming back to him, I checked food sensitivity. So I had this running list of things that if you looked at my list, it was a lot. It was a lot to change. And I have to say, and I'm just saying this for my listeners, that I didn't change it all at once. I noticed that I took one little area and I was like, you know what, I'll take my probiotic. And I was noticing I wasn't doing the exercises. So that was in the next area that slipped in. It's just one of those, like, if we can be patient with ourselves, it will get there. It's just to say, like, I know you send people out all the time, like you were just saying with therapy exercises. Don't beat yourself up, listeners. If you are still looking at sheets of paper that your therapist gave you and you're not doing them, just start them again. Just, like, bring it back in, pull it back in. So I just want to take an opportunity to say that really fast while we were already on the topic, because a lot of people beat themselves up that they've been there, gotten the exercises, and they tuck the piece of paper away and never look at it again. So
Yeah. And you have to go, all of those great things to say, like, how do you eat an elephant? One bite at a time. The
yes.
road to 10 miles is one step starts with, so all of those things take momentum to build. And, and that's always the pressure on the practitioner to, in the beginning, the easiest way to motivate yourself to do things is to do something that starts getting you to feel like it's making something happen. And we all try to do that. And I hope people really understand that, is that we do, I want to give my clients quick fixes to give them the experience of breaking up that lost hope of feeling like nothing works. And if I can give them a rapid fix that they go, this got better or this changed, and I go, now good, it's probably not going to stick. So now you got to do your homework. So we're looking for that. And a lot of times it feels like an uphill battle when we're not able to identify quick wins. And unfortunately, some chronic conditions require multiple steps, because there's not a big bang. There's not one thing that will make a 70% difference, but there's 20 things that'll make a 5% difference. So, and when you do all of those little things, it starts to accumulate. And that's the problem, is that motivational factor of understanding that the summation of our efforts will pay off. But that requires that hope. And the challenge with those chronic conditions is that they have lost the wantingness to tap back into that hope because they don't want to be disappointed.
Right. It's having the faith, the hope and the faith that your work will pay off.
Yes.
But you just might not see it yet. We need to talk about your book. Why didn't my doctor tell me that? What can people expect out of your book?
I wrote this book first and foremost. The book was about saying, telling people, hey, I don't want to just talk about stuff that sounds like it's anecdotal, because in our field, in the alternative health field in particular, there's a lot of anecdotal stuff, and most of it is junk, right? People come up with things that sound really good. They're logical fallacies. When you dive into the research, you find that's not true at all. So I went into that, and all the things that I have found over the years, which I love doing, because intuitively, if you pay attention, you start to find that certain things work. And I'd go into the research and I go, what does the research say about this? Does it support what I think is happening? And sometimes you find that it does, and sometimes you don't. So what I wanted to do is to take all these most common themes when it comes to pain, in particular, the structural end of things, which is my world of things, and start looking at what the research says on this. And I've accumulated tons of resources. I follow lots of great pain neuroscience, physical therapists, and so forth, and always kind of accumulating all of this information. I said, this is all so good, and I want to synopsize it into sections, but also kind of add my own thoughts into this. So some of the big whoppers there is talking about things like, for example, I'll tell people here that one of the most common associations to structural pain or physical pain is issues like posture. It's amazing to me. I started off in this field when I was about 19. So I really haven't done anything else with my career. So I've been in this for about 20 years. And when I first learned it, the functional training exercise revolution was starting around 99, 2000. And that's where everybody was starting to look at posture, and they were starting to look at a body alignment. And, we found even then that a lot of the research was just not supporting some of the things that people were saying. So for example, posture and pain are not that related. And I know that still in 2021, we're seeing internet pages, Instagram pages, and so forth, putting out tons of information, have millions of followers, that somehow if you fix your posture, you won't have pain. But we know in the research for a long time that that's been proven not to be true. You can't look at someone's posture, just like you can't look at an X-ray and determine who has pain and who doesn't, because the stats and the research don't support it. Now, certainly there's a relationship between moving your body and how you feel, but also programming in this bad information that you're not going to be out of pain until you have perfect posture. That's not true. So when I put that stuff in the book, a lot of times that's a big highlight to people, and being like, wow, I'm obsessing about my posture all the time. I also have realized that it doesn't make my back better or my neck better, but that's what I was taught. And no wonder why I'm going in the wrong direction. Sleep was another one. And in particular, the research in chronic pain, the number one thing that affects chronic pain, it seems, and is most beneficial, is getting better sleep.
Wow.
So people come in and they're like, Sam, I want you to fix my muscles and whatever. And I'm like, well, you don't sleep. And then now you're going to send me off to a sleep specialist? Well, not yet, but I'm telling you that you're going to get almost better results starting with that. And mostly it's because I will get better results with what I do if you sleep. And explaining that to people, that nerve sensitivity is driven. Of course, they take master's students, probably is who they're poking on, but they go in and they poke them with needles and they do pain sensitivity scores, and then they deprive them of sleep for a few days, and then they test them again. The scores go off the charts. They can't tolerate it well. So it increases their sensitivity. It reduces their coping strategies and ability to cope with sensory stimuli. So the worse your sleep is, the more you're going to have nerve sensitivity. And oftentimes the result of this is that load gets kicked into the physical practitioner's office, that the therapy is not working. It's not that therapy is not working. If you're drinking 2 gallons of coffee a day and you don't sleep at night, then you're not going to respond well to the therapy. The therapy might be exactly what you need, but this other thing is the reason why it's not working. So a lot of times we get into this syntax battle, meaning the order of operation in which things need to be done because of a hierarchy of what makes the biggest difference becomes a little bit of a challenge. So again, I wanted to address that in the book. So we talk about caffeine. That's another one. What does caffeine do to this system? And, I used to think that for a lot of time, caffeine is horrible for people with chronic pain. Research says opposite. Caffeine is a great analgesic. It works well for pain. And I'm like, well, I still have a conflict here, because the problem is that sleep is a big issue.
Mm-hmm.
Caffeine disrupts sleep. Nobody talks about that. So when we see these internet memes coming up all the time, giving people permission to drink a gallon of coffee a day because, all of those nutrients are beneficial for your liver, but yet they're not putting it into context of all of the negative things that happen by doing this. So when I bring this up to people, and oh, I thought it was okay. You're not sleeping and you're drinking too much coffee. So that's the stuff that I kept when I wrote this. It was so much for my benefit. And then after that, I'm like starting to talk with people about this stuff. And again, the topic kind of became crystal clear. Why didn't my doctor tell me this? Why did my doctor tell me that I should know more about pain and that will help me? Or if you explain it in a better way, that sets my mind at ease. Or I didn't know this. So there is a little bit of a cognitive, just that kind of like informational approach of just dumping information into your head about pain. We still have to put it into action, into the behavioral element of it. But I still find that in this part of where we're at with all of this, that informational component is massively missing. So we're just not even at that stage yet before we even get to the implementation part.
Wow. Yeah. Wow. So cool. Are you on Amazon? Where can people get your book?
No, the book is free. That's the good news. And yeah, exactly. I want it to be a work in progress. At a certain point, I'm really going to bump it up and do a lot more with it. But right now, I want people to have access to it. It's on my website, releasemuscletherapy.com. If you just scroll all the way down to the bottom, I offer a free membership area where I just put all my resources in there in pain tools, recommendations, a lot of new videos and so forth that I put into that area. And you can download the book inside of there.
Oh, that's fabulous. So, and you're starting a podcast.
Very exciting.
Yes.
And just have to say congratulations, because it is an immense amount of work. And yeah, so I'll be doing it. I got the first one done, and I'll be having a few more. But of course, my guilty pleasure is going and grabbing experts that I really have a lot of questions for. And so I get to ask them all of this stuff. So that's great. And of course, the trail off for that is a lot of other questions. Everybody basically gets to listen in as I ask those questions as well. But the name of it is going to be Who Knows This? And again, it's just kind of like that idea of, where I went with my book, which is, sleep. And now I have a bunch of questions about sleep. Who knows this? And I got to go find somebody. Got to go find somebody.
Talk to me. Yeah.
Yeah. And who's going to answer all of my questions? And that way we can kind of fill that in, because we're still left with a lot, stuff. And this is kind of what we talked about, is that once you know something, then the next question comes up. It's like a spring that comes right up after that. Well, what do I do with this? How do I implement this? And, in the world that we're in right now, with so much accessibility with information, it shouldn't really be that hard to find. And that frustrates me. So I'd like to provide solutions for that.
Yeah, yes, I love it. What I can see happening with your podcast too is that you will keep getting the right people to interview. I feel like this is going to be really cool to tune in, and I'll end up binging on these episodes, because it is going to be all that information where we go, yes, who knows this, and why haven't we been told this? And you're right in my space. I feel like I could geek out talking all these topics with you all day, because I know, I just feel this was a specific thing that happened with my family. Was my dad was at this hospital in Columbus and was pretty much given, and long story short, I have lost my dad, but when he was in this specific instance at this hospital, they were done. They had like run out of what they could do with him. We ended up in Cleveland Clinic, and these doctors who lived in this world, who this was their specialty, were like, oh, here are our next 5 options we're going to try with him. And so that was just a medical moment for me of aha, going, how is this so different than this other hospital that I totally respected? And I feel like that's where you're just going to go with all these different topics. So thank you for taking those deep dives. That's amazing.
Yes. And the other part that's going to be the best part is, one of them in particular will be talking with an expert who's a physical therapist on using dental orthosis devices for how it changes cranial and neck problems. And nobody knows this. He's the only person I've ever seen who knows this. It's so complicated, but he'll make it simple. And then the next question is going to be, hey, if anybody on here is a dentist and wants to get into this, contact me. So, getting all the practitioners, if we're all talking about the same thing, I think we're naturally going to start being able to accumulate reference. People ask me all the time, who do you know in this area? Who do you know in that area? And I'm like, you know what? let's start putting the database together of practitioners who are on board with this idea and want to work as teams for the ultimate patient care.
Right. And wait until you are that 1 year, 2 years in, and you look back over your database and you have automatic, like, it's episode this, it's episode that. It's the best feeling in the world to know that you have it at your fingertips and it's yours for
I am
everybody.
I'm very excited.
Yes. Well, congratulations
Thank you
on
so much.
everything. Yes. Thank you so much for joining us today. And again, if any of our listeners want to find you, shout out your website again.
Releasemuscletherapy.com.
Thank you again, Sam.
Thank you.